Hello, hello. Oh, hello. Well, welcome everybody. Thank you all for coming. My name is Alex Wade. I'm the director of the University of York's Centre for Future Health, which is an interdisciplinary funding body, partly funded by the Wellcome Institute, partly funded by the University of York, and we're co-sponsoring this event. And because we're co-sponsoring it, I get to chair it. That's largely my only contribution to the field of mental health at the moment. So fortunately, we have people to stand in here and speak to their expertise. So just a couple of housekeeping things first. Obviously, we all have our phones off because they're a large source of mental health disorder, but also because they'll disrupt the proceedings. The fire exits are here and here, and as the joke goes, you can just follow me when the fire starts. I'll be first out. And just to note also that this event is being, so thank you all for coming in person, but there is apparently a community who are watching this live streamed via the WHO, and so there are many more people attending here than are present in this room. So this is how it will work. We have some wonderful speakers here. We're going to allocate them each 12 minutes to speak on their topics, and I will be ruthless. I have a little piece of paper here saying 1 minute, they have to get off. At the end of that, so during the interchange between speakers, if you have a question that really can't wait, something that's burning, I think we can take one question while the speakers change over. But otherwise, save your questions. And at the end of all the presentations, in about an hour, we'll have everyone sit down here, and then we'll have an open discussion where I'll move around the audience and hand you the microphone, and you can ask questions of the speakers. Before each speaker starts, I'll just have a 20-second introduction to each speaker, so I don't eat into their time too much. And just a bit of overview. So the world is experiencing a mental health crisis, it's clear. And some of the reasons for that are also clear. So there's a demographic change on the planet where we're living longer. That's probably a good thing. And the planet is aging. And so that brings with it an increase in the diseases associated with aging, neurological disorders. But it's also clear that there are some very complex other reasons why mental health is being damaged across the planet. And those reasons are to do with gender, with equality, with justice, with history, and with all sorts of complex interdisciplinary issues that the University of York is particularly well placed to research. And so we've assembled a panel here of experts across the domain, people who have experience in lab work, who are doctors, but who also focus on the social and political aspects of mental health disorders. So enough about me. I'm going to introduce our first speaker, Dr. Soumitra Pathare. He's an MD PhD. He is the director of the Centre of Mental Health Law and Policy for the Indian Law Society. And he's involved primarily in India's first national mental health policy released in October 2014. And given the population of India, you can imagine the scope of that impact. He's now engaged in a wide range of projects, too many for me to list here, relating to mental health and suicide prevention. But I would just mention one, so Atmiyata, is that correctly? A project that provides basic mental health interventions to women across rural settings in India. And welcome to our first speaker. Thank you.
Thank you. Is that what you want? Oh, if I want to do that. Yeah. And to move back in front is just...
back is that
one?
And that front is the big button.
Oh, the big one. Okay. Hi, thank you. Thank you so much for asking me to come here and speak. So thanks to Sanjay and to Alex and the University of York. I'm going to try and talk about my work in India. I primarily work in India. My center does a lot of international work, but I'm going to focus on our work, particularly in India. And I want to try and get across to you that mental health is unfortunately primarily seen as a health issue, whereas we should actually de-emphasize the health aspect and emphasize much more of it as a developmental and a human rights issue. And maybe I can get this across to you in 12 minutes. Tough job, but let's try. This is a extract of a newspaper report from 2001 when we had 25 people who were tied to their beds in a mental health institution in India who died because there was a fire in the place at night and they couldn't even get out of their beds because they were chained to the bed. And so they got burned to death in their beds. This is a mental institution run by some religious group, and there are many such mental institutions in India which are run by religious groups. And then that really catalyzed a lot of attention towards mental health. But if I can take you back a couple of years before that, in 1999, the Human Rights Commission got worried about the state of mental health institutions in India and commissioned a report which kind of quaintly called as quality assurance in mental health. I can tell you there was no quality and there was no assurance, but that's the name of the report. And this is an extract from that report. I think it speaks for itself of the state of mental health care in one of the institutions that the commission's team visited. This is another extract from that same report. Basically, what they were saying was that human rights are violated. Neither staff nor patients are aware what constituted human rights. So this is 1999, and post this report and the 2001 episode, government put in a lot of money into mental health, into upgrading these facilities. And what I think most of that money went into upgrading was most of the places got a fresh coat of paint, got some new furniture, and that kind of stuff. But the National Human Rights Commission thought, well, things may have improved. So 10 years later, they decided we'll review all of these hospitals all over again and do another report. So this is a report in 2008 when they went back to the same hospitals to see what had changed with all of this money that had gone into mental health because of the earlier report. And again, you can read what's up there. This is just one extract from that report. This is another report which says that majority of mental hospitals in India are out of date, designed for detention and safe custody without regard to curative treatment. I want you to guess which year is this? Go on. Come on, let's make this a bit interactive. 2017. Any better guesses? 2019. Sorry? 2019. Anything else? 14. Okay, let's see when this was from. This is 1946. Okay, this is a report done in 1946 because they had this problem. Then this is another report which I want you to look at. This is an extract from the report. It does actually give away the age of this report. Do you want to guess when this is from? Go on. You said 19? Close. 57? Not really. It's actually from 1938. So the point is, we've had these situations going on for hundreds of years. We've had these periodic inquiries. We have this periodic kind of same reports coming up, and periodically the government puts in something to do something about it, and nothing really changes. And that's largely, I think, is because we disregard the entire notion of mental health care by reducing it down purely to a healthcare issue. So anyway, this is what has been happening. And then in 1948, this is from the Universal Declaration of Human Rights. This is Article 1 of Universal Declaration of Human Rights. It actually should read, all persons except people with mental illness are free and equal in rights and dignity. Because that's how it is all across the world. Not just in India, but everywhere. You know, although it doesn't say that, you need to read into that. But we seem to have forgotten that everybody, including people with mental illnesses, have the right to just be free and have a dignified life. And that's just not happening. This is not an Indian issue. I'm sure it's across the world. I'm sure there are conditions similar to this even in the UK at places. The Convention on the Rights of Persons with Disabilities is something that came up about 10, 11 years ago. India was very much an enthusiastic participant. Our government signed the convention on the day it opened for signatures and ratified it within 6 months. And one of the things that came up because of ratification of this convention is that India decided that it had to look at all of its legislation and policies and how things were done differently. And so one of the pieces of legislation that they decided needed reform was the Mental Health Act. We had a Mental Health Act which used to regulate mental health treatment. And so from 2010 to 2018, when we got the law, I was involved in the process of drafting this new act. We ended up in 2018 where we got this new act which is now called the Mental Health Care Act. And you know, it got a very good press. It said it's very progressive, it's getting thumbs up from civil society. Our press was very pleased with it. And why was that? There were lots of provisions which are very interesting from an Indian perspective. We decriminalized suicide. So until 2017 in India, attempting suicide was a criminal act. You could go to prison for a year. You could get prosecuted for it. And some people would get prosecuted for it. We banned chaining of persons with mental illness. We banned seclusion, which was very regularly happening. And we created a right to mental health care, which is interesting because India now you don't have a right to physical health care in India. Right to health care is not a right, not a statutory right or a fundamental right. But because of the Mental Health Care Act, mental health care is a statutory right. The right to mental health care is now a statutory right. There's provisions for advanced directives and nominated representatives, and there's a whole charter of rights that the Act has. And the government was very pleased. We did a pretty good job of it. Everyone's been patting themselves on the back. The Supreme Court liked it. In fact, the Supreme Court used the provisions of the Mental Health Care Act when it commented on homosexuality. Section 377, which was criminalizing homosexuality, was found unconstitutional a year ago. And these are extracts from the judgment where I'm going to show you that, which basically said that homosexuality is something that even the Mental Health Care Act regards as not being legitimate grounds for criminalization, and so they decriminalize it. So the Mental Health Care Act actually had an impact on something as unrelated as the decriminalization of homosexuality that happened at that time. And interestingly, they said that if sexual orientation is not a grounds for discrimination under the Mental Health Care Act, then how can it be grounds for discrimination under any law? Because we are the first law which actually said no discrimination on the grounds of class, sex, gender, and sexual orientation. It added sexual orientation into it. There was also great press from British Journal of Psychiatry, had an editorial recently talking about how India has really progressed ahead of everybody in terms of implementing the CRPD. And recently you had the report from Sir Simon Wesley's report on reforming UK's Mental Health Act. And this report actually quoted the India Mental Health Care Act as being very radical, and so that they were not going to do anything as radical as the Indian Mental Health Care Act has done. So you think we've really done a great job and everything is wonderful. So this is what you see just last month. Hundreds of mentally challenged people chained like animals in Uttar Pradesh in a mental health institution. So we've changed the law, we've got things to become progressive, but the real problem is things don't necessarily change on the ground. And I think the whole issue around implementation, which comes up, is a real problem. Unfortunately, this time the Supreme Court took immediate notice of this and pulled up the government and said we need to kind of do something about it, refer to the Mental Health Care Act, and got these people unchained and released and sent back to their families. But we have lots of implementation problems. Our courts have got really active into it and have been emphasizing there's something called as review boards, which are there to protect people's rights when they go into mental health institutions. They've not been set up. Many of the states don't have resources to do anything for it. So I think what I wanted to capture in this very short presentation is that we need to actually stop seeing mental health purely as a health issue. If we started looking at it as a human rights thing, then we would actually implement things far better and implement the kind of things that are required for people to have an inclusive life and be included in society. I think I've used up most of my time. I'm ahead of schedule. So, I just have a last one slide to kind of go through. This is something quite helpful. My friend Oliver Lewis, who's a law professor at Leeds, made this slide, and I always like using it because he says states can sign a convention, which is a promise to do something about it, or they may ratify a convention, in which case they say, oh, now it's legally binding on us. But the most important thing is whether they will implement the convention, which is when people will benefit. And I think the real challenge worldwide has not been the challenge of signing and ratifying. Almost every country has, I think the UN, almost everyone has signed and ratified the Convention on the Rights of Persons with Disabilities. The real challenge is implementation. And I think what we need to do is, I think what international organizations need to do and what internationally we need to do is we need to actually move some of the development funds into mental health from a rights perspective. There's a lot of rights-related actions that the world takes, and there's a lot of development-related actions that the world takes. But we don't actually look at mental health as something that fits into that rights and development discourse. There's the big thing about the SDGs about leave no one behind. The fact is that we are actually leaving people with mental health problems behind across the world. In India and many other low and middle income countries, and I'm sure also across high income countries. I'll stop here. I'll give you some time for use with someone else then. Thank you so much.
Thank you. So our next speaker is Professor Martin Weber. He's the director of the International Centre for Mental Health Social Research here at the University of York, and his work focuses on the social dimension of mental health, leading to the development and evaluation of a social model of practice which helps people improve their access to social resources within their networks, a lot of social. A program which has been adapted for use in both high and low income countries. Thank you.
Thank you again for the invitation here to this seminar. The first thing which you may notice about me is that I am from the UK, and I'm talking about working in low middle income countries. So part of this talk is going to be about how we do our work with low middle income countries, but particularly I want to address the social dimensions and the complexities in addressing social dimensions in mental health. And allied to this is my background as a social worker, and I'm considering how practitioners can work to address what are global and very large determinants of mental health. So we know a lot about social determinants of mental health, we know less about how to tackle them. So our mental health is shaped globally by the society in which we live, social, economic and physical circumstances and environments we find ourselves in. Inequality is correlated with common mental disorder in particular, and action needs to be taken which is universal across all of society. It is a public health issue, as we will be discussing in this seminar. Actions need to be taken at different levels across the environment, in terms of the structures in which we live, and also locally, and within particular subgroups in the population where mental health is particularly a problem. And as I said at the top, the social dimensions are particularly complex to address. And I really want to provide a couple of examples of some of the work which we're doing, not necessarily to provide solutions, but to open up the discussion about how we can engage with and address some of the complexities. And in relation to our work which we are undertaking in the two countries which I'm going to give examples from, following on from the first talk, I'm going to talk a little bit about our work in India, first though around Nepal. We developed a cultural adaptation framework as a roadmap for thinking about our experience in the UK and other countries, the high income countries, and how some of this experience can be used to help local people, local practitioners, local researchers in different countries in terms of developing their own practice and developing their own evidence base. And we've been trying to avoid a neo-colonial model. And this is one of the challenges of working from a high income country, particularly in countries which we've had a long relationship with in the past, to respect and understand the local context. And social interventions are often embedded within a local society, a local culture, and its local context. And therefore, taking something from the UK and putting it in a different country, quite clearly, is inappropriate. It doesn't work, and it's wrong. But this is what we have used as a way of using some ideas from an evidence base which has been developed, taking that into countries where there isn't a similar evidence base. We've done some work with some colleagues in the Freedom Fund with bonded labourers in Nepal. Here's an example of a group who face structural oppression, among whom mental health problems are understandably very, very prevalent. High rates of depression, anxiety and post-traumatic stress are here in this population. But traditional Western methods of treatment are arguably not going to be appropriate. The first thing is to deal with the debt bondage in which people are experiencing. The Freedom Fund are campaigning, fighting for that. But they're also putting in a programme of work with a local psychosocial NGO, which is aiming to provide counselling, but also psychosocial interventions. And that's really where we came in, to think about how can we address some of the social isolation that people are facing. How can people build up good human relationships with their neighbours, with others in their local communities. And we've drawn upon some work which we've undertaken in the UK around connecting people to inform the local thinking and the local training in terms of supporting bonded labourers in the southeast Terai area of Nepal. Briefly, Connecting People, developed in the UK, focuses for social work and other mental health practitioners and support workers around supporting people to enhance their social connections, with the aim of building trust with supportive people, enhancing connections in the community, enhancing resourcefulness within people's networks. And we really wanted to see, can a similar approach, can something be adapted for this particular group of people? We undertook an iterative process of development with the local NGO that we worked with in CMC Nepal, and they developed the Barossa intervention, which combined some psychosocial intervention, but also around thinking about how resources within the local community could be mobilised to provide support to people. And we drew upon our conceptual framework as a way of iterating the development. And the process which we have undertaken has been evaluated, and I'm going to talk very briefly about some of the difficulties with this, but also some of the findings and where we go next. One of the key things about this is the fact of training local people, the community facilitators who are undertaking the work, and we've developed a model of training supervisors so that the programme is not a standalone programme, but can have its own life cycle after the end of the project and the funding came to an end. So in brief, we piloted the training. We looked at the social outcomes, looked at the health outcomes using the GHQ, the General Health Questionnaire for mental health. And we just did a pre-post study with a control group. The intervention group and the control group were in different localities, and this is one of the difficulties with interpreting the findings. Now, we found very briefly here that the bottom level is mental health, that we found a reduction in GHQ scores in the intervention group and not the control group. We didn't find the same in the social support measure. And we think here that the measure itself was not sensitive to change. It was also what's known as the ceiling effect, that everybody had access to a lot of these resources that were in the measure to start with. So the measure itself was not as robust as it could be. Also, we can critique what we're doing and think, are we actually just addressing the psychosocial needs or the wider social needs? In a complex intervention, it's often difficult to work out what the essential ingredients are and what the outcomes of those are. Also, in the middle of this, there was flooding, there was elections which got in the way, as it were, in terms of the delivery of the intervention, and also in some of the collection of the data that we collected in the middle. But this is real life. This happens quite regularly in this work. I think the thing to say from this finally is that we did notice behavioural change locally as a result of the intervention. So for example, the community facilitators who were trained in the delivery of this approach were picking up people more readily who had mental health problems and referring them to appropriate support. Also, the psychosocial counsellors felt better supported in their work as well. So it's only a pilot. We're hoping to continue the work elsewhere and to refine some of the measurements to get better data locally. Now, secondly, in India, I want to talk about some of the consequences of Soumitra's presentation around mental health being a human rights issue. One of the biggest consequences is that mental health has a huge stigma in India. Across the world, that's a very, very common feature, but in particular in India. Now, globally, non-communicable disease is the leading cause of mortality, and we've seen this in India as its economy has become richer and people's lifestyles have become more Western. So you can see from the blue ones here are the non-communicable diseases that they are on the rise, and they have been very, very high in terms of leading causes of mortality. Mental health problems have a role within this, and that's really what I want to talk about. In relation to Kerala, southern state, bottom left-hand corner, where non-communicable disease mortality is the highest in India. What are the problems in addressing non-communicable disease, in particular cardiovascular disease, diabetes, for example, are the numerous risk factors that are involved. And you cannot just address one, well you could, but you're only addressing part of the problem. Mental health has a cross-cutting effect across each of these. So for example, with high blood pressure or high glucose levels, mental health problems have an impact on them. I want to talk about how that occurs. So for example, the chronic diseases of diabetes, hypertension, leading causes of death, disability in India, and we've seen an improving socioeconomic status across the country, in particular in Kerala, which is associated with reduced physical activity and increased obesity, diabetes. Social networks, which we know that social networks are protective of depression. We found that with evidence in India and in other countries as well. But as we've heard, stigma prevents access to mental health services. This is for people with depression and anxiety. It's treated more often than not within the family, and the healthcare costs are met within the family. And if a family doesn't have the money to pay for treatment, then people within the family go without treatment. We're working with a College of Social Sciences in Cochin in Kerala to develop the capacity of the college to research and intervene locally. So we have some funding from the UK India Education Research Initiative, and we're developing a research team who have undertaken this work. And given that I've got a minute left, I want to fast forward to some of the issues which we've come across. I want to talk just very briefly about one of the dimensions of the work, which is a community survey which we've undertaken, a sample of 1,000 people looking at the risk factors for the management of chronic disease. So we're looking at some of the social risk factors, behavioural risk factors, mental health, as well as some of the physical symptoms. And I'm just going to talk through two slides. First of all, we looked at trying to identify homogeneous groups of variables, risk factors which are associated with the chronic disease prevalence. And we've identified three. Class 3, the grey one, is the low risk group. But I want to talk really about Class 2 in the red line, which is what we've termed a social risk group, where people are physically inactive, more physically inactive than others, where there is particularly low income, low levels of literacy, and high life stress, disintegrated social networks. In contrast with the behavioural risk group, where smoking and alcohol use is more prevalent. And looking at the socio-demographic composition of these groups, we found that older women who are not married, not in work, and not with a very particularly low income and a poor marginalised position within their communities are within the social risk group, and more younger men are in the behavioural risk group. So just to say that any behavioural interventions could be targeted towards one sector of the population and missing women who are in the home and often arguably invisible. And I want to end on this note of complexity, that we're just undertaking some modelling, not looking at just individual relationships between one variable and an outcome, but really the whole complexity. Imagine this as a 3D model, where you have on the left-hand side, I don't know if this is the pointer. Oh, here we go. Right, great. Up here, we have the blood pressure, F1 and F2, are high blood pressure and blood glucose. Now, these are risk factors for cardiovascular disease. And we have clusters of variables. These are social cohesion, social network variables. We have wealth, education here, and the B clusters are behavioural variables, and over here we have mental health problems. Now, mental health problems may not have a strong direct relationship, but they impact on physical activity, for example, and other behavioural risk factors, which again have an impact here. So suffice it to say, intervening needs to take account of the social context, and just recommending lifestyle change, for example, isn't going to be sufficient without addressing mental health as a core component, but also some of the social network factors as well. Thank you.
Thank you. Thank you, Martin. So our next speaker is Dr. Maria Teresa Ferretti. I hope I've said that right. She's a neuroimmunologist and science advocate with over 10 years of international experience in the field of Alzheimer's disease. Dr. Ferretti is one of the founders of the Women's Brain Project, and we have two speakers here today who are associated with that project. It's an initiative related to identifying the needs relating to women's brain health, advocating for change, and positioning the findings for the benefit of society. Dr. Ferretti is the Chief Scientific Officer at the Women's Brain Project, as well as a scientific team leader who works in the lab to identify novel biomarkers for the early detection of Alzheimer's. Thank you. I'll just do this. It's a bit annoying.
So this is forward and this is point?
Yeah.
Good morning, everyone. It's really a pleasure to be here, and thanks for the kind invitation. I'm actually glad that Martin introduced a little bit the topic that I would like to propose and bring to the table. I'm adding an extra layer of a dimension of complexity to what we've been discussing. We've been talking about human rights, we've been talking about the social dimension of mental health. My job today with my presentation is to talk about how important it is to consider diversity when we are planning preventative strategies and interventions and treatments for medicine in general and mental health in particular. And I will argue that sex and gender differences, or differences between men and women, are really the starting point we should consider and are the gateway towards precision medicine. However, these, quite surprisingly, have been quite, I would say, neglected, not properly considered until here. And for the rest of the presentation, what I would like to do today is really to give you an overview of some of the most important sex and gender differences that we are aware of in medicine at large, and why these are important, and the different levels at which we might be missing these differences, and we should think about it. And then I will leave it to Dr. Santuccione-Chadha to actually give you a very specific example in Alzheimer to give you an idea of how important this might be in a very specific case. So let me start by stating the obvious, that men and women are different, and I think we all agree on this. However, for a very long time, medicine assumed that the difference is only related to the reproductive system. So women's health is only and exclusively bikini medicine, anything that is related to, let's say, giving birth or breast cancer. Actually, we now know, thanks to gender medicine, that women's health and sex and gender differences go far beyond this. And virtually any organ and system that you can think of in our body is different between men and women in their function, in their response to treatment. This applies to musculoskeletal system, to metabolism, so diabetes, cardiovascular differences. The immune system is profoundly different between men and women, the brain, and the way we absorb, metabolize, and respond to drugs. So is this important? Are these differences really something we should think about, or is this something that just happens to be like that, but more or less we can just assume that we all respond more or less in the same way? Of course, I will argue that this is important. I would like to give you two examples of two drugs that are currently in use that were developed most likely not properly considering sex and gender differences. So this is something that we realized only when the drugs were on the market and already used. So example number one is aspirin, which you all know as an anti-inflammatory drug, but it also has cardiovascular protective effects. It was only in 2005 that the clinical data related to this aspirin cardiovascular protective effect were analyzed stratifying, so separating female and male data. And only then we came to realize that actually aspirin can prevent heart attack, can prevent heart attack in men, but not in women. So for a very long time, this was administered to women that most likely did not need it. Another example is the so-called Z drugs. So these are insomnia drugs. The most famous of these is zolpidem. These drugs can cause quite severe, important side effects, especially next morning impairment in driving and cognitive impairments. After the drug was already on the market, FDA realized that these side effects were much stronger in women than men because the drug is metabolized in a different way. So basically, women absorb much more. And so there was actually an official communication by the FDA stating that the dosage for women should be actually lowered. So the FDA is saying for women we should lower the dose. And again, this is something that we came to realize only at the pharmacovigilance level, and we never realized because this was not thought about before. So these are two examples of things that could have been done better, let's say so. So this is what I would like to argue, that to improve our current thinking for medicine in general and mental health in particular, we should take into consideration diversity in general and sex and gender in particular. So where did things go wrong? And at which level can we improve our thinking? First of all, we start from the lab, from the basic research. This is a huge topic. Especially in preclinical neuroscience, there is a bias in the way we do basic experiments, so mostly using male mice. I'm just showing you some statistics from a very specific field where you can see that about 40% of experiments are done with male only, the light blue ones, and actually a very large number are even, the sex of the animals is not even reported, so we don't even know. And why do we use only male mice is because there is this preconception in the labs that female mice are much more difficult to work with because they are messy, because of the hormones. So they are more complicated, so we just get rid of them and we just analyze the male mice. And the problem is that then down the road, you completely miss the sex and gender differences. And this has been recently highlighted by Rebecca Shansi, even in Nature. But it's not only a basic science problem. There is a problem with diversity in general, also with human studies. And here I'm showing you an example for genome-wide studies, not really looking at sex and gender, but looking at ethnicity. But I see it as a general problem of not considering diversity in the data that we're generating. So in this paper in Nature, what you're seeing is that from 2009 to 2016, there has been an increase in the percentage of, the increase would be here, in the percentage of non-European ancestry individuals that participate to these studies. However, this is still a minority and is not representing the real diversity that we have. So we are generating data sets that are not really representative of the whole complexity of the system, and they might not give us the full range of information that we need to build on them. Clinical data, but also clinical trials. So it was in '93 that the FDA mandated the study of an evaluation of gender differences in clinical trials. So it was said it's important to look for specific sex and gender differences, so design clinical trials and analyze them to consider these differences. However, unfortunately, again, the implementation, going back to the story of signing, ratifying, and implementing, implementation of this has been difficult. So I'm showing you the results of a report that has been published by the FDA, Women's Health Office, led by Dr. Jenkins. And what has been shown in this paper is that even though there is an improvement overall in the past years, more and more women have been included in clinical trials, the percentage of women in clinical trials is still not really reaching 50%, is much lower than that. So we are not including women in clinical trials enough, especially for certain indications, so again, we are lacking data. I also would like to move away from basic science and clinical science, which is my field, and just to give you a glimpse into social sciences, because I know that this is very important to this audience. And I have, of course, to say that 40% of our health is determined by socioeconomic factors, as has been mentioned. And if you think about it, and this has also been mentioned by Martin, socioeconomic factors such as education, job status, and income are strongly affected, let's say, or modulated by sex. So in general, women tend to report lower education, lower income, and lower job status. So when we think about ways to modulate or to address socioeconomic factors, as Martin was mentioning, it might need to be really tailored towards men and women in different ways. And I apologize, this slide doesn't show nicely, but I wanted to bring to the table also the topic of novel technologies and artificial intelligence, because I think it's very actual and modern, and we have to talk about this. The data that we're generating and the way we're analyzing, it seems to be quite biased, and in certain conditions are really, we have shown that these are biased. Here you have the example of gender classifiers. So these are algorithms that have been trained to recognize several pictures of faces of individuals, and then you ask the algorithm, is this a man or a woman? And in general, they work pretty well, but there is one case in which they really fail. And this is when they are given a darker female face to recognize. They are not good at seeing this. And it's been shown that this is due to the fact that during the training, the algorithm was not given enough information, enough images of darker females. So again, pointing to the direction that all these novel technologies and algorithms that we are developing nowadays have to take into consideration the diversity that we have. We have to be extremely careful what data we are feeding this. And taking one point very important is actually the gender. However, I think big data, and we were discussing this before, big data and artificial intelligence might be the solution to our problems, because we have something that is extremely complex. Medical, clinical data can be extremely complex. It's hard for us to make sense out of them, but we have artificial intelligence that might help us. And here is an example of a study that was performed in the city of Blumenau in southern Brazil. You have a population of 3,000, 40,000 individuals, and you have electronic health records of almost each one of them. So what was done in this study, which was published in Nature Digital Medicine, was checking the records for drug-drug interactions. So they checked the type of drugs that every individual was administered or prescribed by the doctors, and they checked how many times or what was the risk of being prescribed two drugs which actually interact. There is a dangerous interaction between them. And of course, this is a huge amount of data, very complex, that was done with artificial intelligence. And the result was that actually women had almost double the risk of men to be prescribed two drugs that interact in a dangerous. This was for serious, major known drug-drug interactions. This is again something that without this big data we would have not been aware. So I think these type of technologies are actually our tool if we want in the future to take into consideration these differences and act on them. So I kind of gave you an overview of different aspects that we should consider in general in medicine and in particular in mental health. And these are kind of the pillars of the work we do at the Women's Brain Project. We focus on four mainstream: the preclinical science with the male-female mice story, the drug development with the clinical trials, the novel technologies, and the social determinants of health and policy science. And we think that these four aspects for sex and gender are particularly important for mental health, and I just want to show you two more slides regarding this. Why mental health and sex and gender differences? Mental health conditions, the most common ones, depression, anxiety, and somatic complaints, affect 1 in 3 people worldwide, so they are very prevalent. 2 out of 3 of these individuals are women, so they are extremely prevalent among women. This is fact number 1. And the fact number 2 is that being man or woman does not only affect the risk to have a certain disease, and here you have a list actually of diseases that are more common in men and women, and there are actually quite a lot. Almost any mental or brain condition you can think of is somehow different in terms of risk, but also in terms of presentation of the disease, in terms of risk factors, in terms of response to treatment. So in particular for mental health and neurodegenerative condition, considering the sex and gender differences might really be a way to implement precision medicine. And this was my last slide. The call to action, as you might guess, is that we should go from a one-size-fits-all approach into a precision medicine approach, an approach that considers the complexity of things, and sex and gender is one of the first elements to think about. We should think about it when we talk about awareness campaign, preventative campaigns, policies for mental health, the novel technologies, when we are designing early diagnosis, because even the symptoms might be different between men and women, and Dr. Santuccione will tell you more about this, in clinical trial design and brain research at large. And I hope that this take-home message will stay with you, and I will just conclude by thanking you and the team behind all the work that I showed you today. Thank you.
Thank you. Oh look, there's you. Thank you. So our next speaker is Dr. Antonella Santuccione-Chadha, the Global Medical Leader for Alzheimer's Disease Partnerships between Roche Pharma and Roche Diagnostics. Roche is a drug company. She's co-founder and CEO of the Women's Brain Project. And she's worked with Swissmedic, the Bill and Melinda Gates Foundation, the EU Commission Directorate for Health and Food Safety, and the World Health Organization. And I believe you're currently advocating for the establishment of a precision sex and gender medicine institute in Switzerland. Is that right? Yeah. Good. Thank you.
So thank you for this kind introduction, and thank you for giving the opportunity to share with you this type of message that Dr. Ferretti has been illustrating to us before. Now I'd like to give you an example of what she has been discussing about in more details. And the example, it is about Alzheimer's disease. Before I go into my thoughts, I have to say that I am here on behalf of Roche, which is my official employee, but views and information contained in my presentation might not necessarily reflect the one of Roche. So what is it, Alzheimer's disease? Alzheimer's disease, it is a progressive neurodegenerative condition that it is associated with progressive cognitive, functional and behavioral impairment. It is characterized by the accumulation of what is called A-beta or amyloid pathology, as well as tau pathology. It results in the loss of synapses and also in the end in neuronal death. This is how the brain of a person suffering of Alzheimer will look like in the end. It's completely shrank, it's really reduced in size. The problem is that we have no treatment for Alzheimer's disease, and it is a huge unmet medical need. When we look at numbers and we speak about the estimated numbers of this pathology, we know that nearly 45 million people worldwide suffer of Alzheimer's disease, and 27 million of those are women. So it is considered that nearly 62% of women are affected by this condition. The women population, it is at higher risk of developing Alzheimer, and it is estimated that the lifetime risk for Alzheimer's disease at age 45, it is about 20% for women versus 10% for men. and the numbers slightly increase when we, of course, get older, towards the age of 65. Now, the numbers in Europe looks even more drastic. This is what has been disclosed by the European Institute of Women Health together with the Women Brain Project, and these are the countries which were analyzed. It seems that prevalence and frequency of Alzheimer in the European population, in the female one, it is almost double as in the male one. We said Alzheimer, it is characterized by neurodegeneration, and we said that amyloid plaques appears together with neurofibrillary tangles and result in the end of the shrinkage of the brain. But when does this happen? The pathology starts very early, in the middle of our life, it is estimated, and it goes on. And this is much before the symptoms becomes manifested. So, in fact, the clinical diagnosis becomes obvious and clear only after decades, when the pathology in our brain starts to happen. The challenges in Alzheimer's disease, therefore, it is the fact that I said that there is no cure, that the diagnosis, it is too late, and additionally that there is a very high interpersonal variability in biomarkers and progression of the disease. Finally, it is still poorly understood which could be the preventive measures to avoid this type of problem later on in life. I'm sharing now with you the story of Sophia. She's the co-ambassador at the Women Brain Project. She's a 41-year-old mother who has been diagnosed with Alzheimer's disease. And why am I sharing you this? Because I want to emphasize the difficulties that there is behind a diagnosis. This is, I think, anyhow reflected in any other type of indication which relates to other brain or mental diseases. It is not an easy journey, as if we compare to oncology, for instance, where we can obtain a diagnosis in a couple of weeks and even characterize to a subcellular level the type of tumor we have. In neurology and psychiatry, we're really far away from that. Sophia basically had to struggle nearly 2 years before she arrived to the final conclusion that she was suffering of Alzheimer's disease, although she had it in the family. So it was known that her family was confronted with this pathology. And she had to, she's coming from Sweden, she had to cross all over the country to finally find the right neurologist with the right tools, realized that she had a mutation for the gene predisposing to Alzheimer's disease, and she was relieved by the fact that she had a diagnosis. Another part of the problem was that the tool used were not good enough to depict the cognitive deficits she was experiencing, being she a young type of patient, let's say. And so she disclosed in the blog that she's writing for that her problem wasn't in fact to draw a line from A to 1, from B to 2, etc. and so forth. It was much more subtle, and that was the difficult part for the doctors to be able to diagnose in the early phase of the disease. Why it is important to diagnose? First of all, as we learned from Sophia, there is a personal empowerment of having finally an understanding of what's going on with yourself, right? And you might want to then construct the best management for you and your family when things might become worse. And then it's also giving you the tool to participate to clinical trials, etc., etc. This might not be valid for each patient, I understand, but at least we should be able to make a choice. Of course, there are also several medical reasons behind it. I mean, certainly we can do some specific, I would say, choices in mitigating the risk of having further cognitive decline or trying to prevent it even. And I'll tell you later what I mean. Research will also benefit, of course, from an early diagnosis, because we will be able to better characterize the disease, to recruit an earlier phase and maybe intervene when things aren't too advanced in terms of pathology in the brain. And finally, there are also studies pointing to the fact that if we diagnose timely in the disease history, there is a reduction in the cost for the health system because the patient is managed better. We were speaking about sex and gender differences. I would like to go back and tell you that even when we diagnose in the early phase of the disease, it's important to consider this aspect. It's known, for example, that women do have a better verbal memory when compared to men in the mild cognitive impaired population, although there are similar levels of hippocampal atrophy in the brain. In other words, women might mask or compensate in the early phase of the disease, the symptoms. And this is creating a problem when you do a clinical trial design, because basically the baseline of your population won't be representative or the same in the two groups. There is also a strong interpersonal variability. We can say that women progress much faster than men towards the disease, and there is a faster brain shrinkage in the female population when compared to men. And this type of data are popping up I would say, not on a daily basis, unfortunately, but frequently nowadays. This is, for instance, also a study that is pointing to differences in biomarkers level. Biomarkers are fundamental in understanding the disease and also during the early phases. And here, Rachel Buckley studied the fact that women do have a stronger tau deposition in specific region of the brain which are affected with the disease by the same amount of amyloid. In other words, women had more tau when referred to amyloid pathology. And this is another learning which has to be taken into account when we do drug development and when we diagnose. Speaking about risk and prevention, a brilliant piece of work has been done by the Lancet Commission, I think so, summer 2017, where they have been trying to characterize which were those risk predisposing a person to develop later on dementia. And what they find out is that 35% of Alzheimer's disease risk, or I would say dementia risk, it is modifiable. And sex and gender certainly affect, in a way, this modifiable risk. For example, we heard earlier education. And education, it is one of the few identified preventive measures not to have later on dementia. And we know that women are less educated in general than men. This is even a bias in recruiting women in the clinical trials for ID, because basically you need to have a certain degree of education to be admitted in a trial, and in general women are less educated, so there is already the bias at the source, but that's another story. Then towards the middle of our life, we have other risk factors like hair loss, hypertension, obesity, and later on in life, it's about smoking, depression, physical inactivity, social isolation, and diabetes. And again, depression, we heard, it is more common in women, much more common, almost twice as much as in men, according to WHO. And finally, also social isolation. Women are often widows, and according to the OECD, the rate of women within the OECD countries which are in a nurse care setting, it is much higher versus men. So there are finally also some female-specific risk factors due to hormonal changes that women do experience, and one of those is the menopause. There are also evidences that suggest that hypertensive complications like eclampsia or preeclampsia might predispose later on to dementia. And finally, also, it's debated the pregnancies themselves. Here there is a lot of research which is going on, and I think further clarification is required. And there is a debate as well that too many pregnancies might be a risk, or the other way around, it's not yet clear. Another piece of information which goes towards risk factor in women was recently published, I think 2 weeks ago, on the Journal of Alzheimer's Disease, pointing to the fact that a study in UK has proven that migraine, it is a specific female risk factor for developing a dementia later in life, which it is another worrisome reflection that we have to consider. Well, I hope that I have been able to give you an overview of why, even when we do drug development, it's very important to consider sex and gender differences in a disease, for instance, like Alzheimer, which is really a burden for our societies and for which there is no cure. So the call to action is really to move, as Dr. Ferretti rightly pointed, from the one-size-fits-all to a more precision medicine approach. And with this, I want to finish, and I want to acknowledge Roche for giving me the opportunity to be present here today and bring across this message. Thank you.
Thank you. So our final speaker today is Professor Carol Brayne. And I'll just set this slide up now for you. I'm just going to tab. So Professor Brayne is an MD PhD, Director of the Cambridge Institute for Public Health. She's lead PI in a group of MRC CFAS studies that have been studying cognitive function in older adults since 1989 in the UK. In 2017, she was awarded a CBE for her services to public health medicine, but far more impressively, to me at least, she's one of the most highly cited scientists on the planet. So thank you.
Thanks very much, and thanks for inviting me. It's fantastic to be here and see such a wide range of audiences and I think of backgrounds. So I've got to just learn this. So I just want to talk to you today about where does our data come from, and that's fed into many of the things that you've heard today. We've heard about primary data from Martin, but a lot of the other data on, particularly for dementia, has come from somewhere. And so I'm going to describe how we've arrived at some of these data and why that is so important to our understanding of contemporary societies and planning for future societies. The picture is not random. As you can see, the beauty of Cambridge, but also the picture on the left is from Cambridge as well, rough sleeping. So this is a kind of an integrative approach. So I thought I would start by saying what my framework of research is, and it's more than research really, because it becomes advocacy as well. So I started out as a medic. I did neurology and psychiatry. I didn't become a consultant in those, but I did junior doctor training in that and general medicine. Then I went into epidemiology. I wanted the risk and the outcome. And those social scientists in the audience will laugh and think, oh, what a fool. But we were brought up on the reductionist theory that you can provide, basically you've got smoking and lung cancer. You've got asbestos and lung cancer, mesothelioma. And for all sorts of conditions, you have a single risk and an outcome, HIV and AIDS later, TB, bacillus and TB, the disease. Of course, it is so much more complicated than that. So public health, I came to public health later. I came to public health through having to be trained in public health almost as a professional already. So I was an epidemiologist, medical epidemiologist, and I became a public health physician through my exposure to training public health trainees in the NHS and through my research. So my own research was grounded in population, and so that's what I'm really going to talk about today. So the public health framing is what is the condition and its context within us and within societies. So there's the reductionist element, and then there's the whole global element, with all of the elements in between. And from a societal point of view, is there any evidence of change in something, in a condition as important as dementia in the population, and what does this mean? So the role of population studies in that regard is we work on areas of importance to society to understand what they look like in the population on the ground. We describe the disorders and states which are identified as key without preconceptions about what they are. The fixed condition might not actually be the same. So if you take asthma and then you go out and you measure FEV1 and all the different things that make up the diagnosis of asthma, you'll find a very different picture in the population, and the same thing applies for every condition pretty well. So then you can learn about the what, the who, the when, the where, and the why. And it gives you empirical evidence with a known denominator, and that's the really important thing about epidemiology and public health, is that it has a denominator. That we know, we attempt to know, I should say it's really hard to know from what population to which population does this information, data, evidence derive and is appropriate. So that gives us the meaning of the disorder or the state for societies, groups and times. And it also allows us to examine risk, protection, life course, natural history. It also allows us to test for changes in diagnostic boundaries and, crucially, changes across time. And so this is absolutely key for all types of prevention, primary, secondary and tertiary. That's public health terminology. Primary prevention is upstream prevention, reducing smoking to reduce lung cancer and heart disease, for example. Secondary prevention is detection early, and breast cancer screening is an example of that. And prostate cancer screening is highly controversial because you need to have evidence of true benefit to the population and not evidence of harm. And tertiary prevention is mitigation. What can we do about the condition when it's there? And that, of course, includes the optimising our end-of-life care as well. So since the mid-80s, I have been doing population studies of older people. And this slide contains the first study I did. It's called Cambridgeshire. And it was a European exercise to bring together all the evidence from population-based studies in Europe, led by Bert Hoffman, who's now at Harvard. And this was really important in the bringing to politicians the recognition that dementia was an important condition and that it was very, very closely associated with age. So this is really old data, you can see. But the basic message has not changed about dementia, although I'll say something about that in a moment, that it gets much more common as age increases, and there is an increased prevalence in women compared to men. I'm not showing that here. What I'm showing here is emphasizing the linear. If you put dementia on a log linear scale here, it's linear with age, which means that it's rising, it's doubling every 5 years after the age of 65. And that pattern of age increase is seen across the world. Whatever your starting rate, you see that across the world. Even though dementia as a syndrome, when you work as an epidemiologist, it's really hard to pin down. You have to measure cognition, functional ability, that's day-to-day activities. You have to know about physical activity, and you have to know about consciousness. I know many of you in the audience are not medics, but these are life, this is about lived life here. And in the dementia criteria, you have to have impairments in these and intact consciousness. And not have physical conditions that explain the poor function, as it were. And then you get shunted into meeting the criteria for dementia or not, intermediate, mild cognitive impairment is one way of characterizing that, and then not meeting any of those, and then you're normal, so-called normal. And that becomes increasingly rare with older age. And you can then measure all the biology on the right-hand side, all the different tests which happen to be in fashion. And here I show omics, well I don't show omics, but I show there's beautiful, beautiful imaging pictures. But of course we have been there before with phrenology, so we do need to be cautious about our own novel methodologies and think we need to understand we are scientists in our time. And you can do all those things, and then you can get this I'm going forward, not back. You can get this sort of mixture of sweets, pick and mix, and you can actually characterize people as having dementia, meeting the criteria for dementia syndrome or for mild cognitive impairment, and get a huge range of different people into the diagnostic criteria depending on how you operationalize or implement those criteria. So this is really hard for epidemiology and public health, but the basic clinical syndrome, you always have to come back to the thing that what matters is what's happening to people in their lived lives. And to try to make sure that what we're doing on the right-hand side is, we can't call people who have characteristics in their brain that might suggest they have dementia, but who don't have these things. We can't call them demented. And we need to be very, very careful that we're not blurring all the boundaries with our beautiful fashions. So we can come back to that. So why do we have such different opinions about what there is, what dementia means? And part of it is about dementia being very, very diverse, very heterogeneous. So there are the tragedies, or not tragedies, maybe maybe optimistic stories from younger onset Alzheimer's disease detected at a relatively early stage and supported and may be able to do all the things that keep things going. But the vast majority of people with dementia, as I've shown you, are in the older age group. And they are seen in end-of-life care, in secondary care, and to some extent in psychiatry services and neurology services. And people present through their primary care or through hospitals in different ways, and they have very different characteristics. So if you're a psychiatrist and you think you know all about dementia, you know about the dementia that you see. Your denominator is patients who have been referred to you through the Goldberg filters. So every system has a set of filters. And when we do the population studies, we see the whole mix. So we see how diverse it is and how the one-size-fits-all message is absolutely wrong for conditions such as dementia. And this is emphasized by the type of work that we do. So one of the studies that I've been privileged to lead is the cognitive function and aging study. And this has, it's a big population study. It provides the estimates, the numbers that were in Antonella's slide at the bottom for male and female are based on our study. But we have brain donation in this research. And we've been able to look at what are the pathologies that contribute to dementia in the population. And you get a slightly different picture if you do that compared to some of the analyses which are based on more clinically orientated approaches. And what you see here is if you do a population attributable risk analysis, and this is on a substantial number of brains of people who've died with or without dementia from the population who've donated their brains to our research, is that 20% is related to sort of extreme age or mid-older age. Brain weight is really important, so that's the atrophy, and you have atrophy with aging as well as with specific dementias. 20% from the barn door Alzheimer type pathologies, 20% from vascular pathologies, which have been massively neglected, and around 15% from other pathologies. And we've added in a new thing there called hippocampal sclerosis, which probably adds a little bit more in there and a bit more detail. So it's much more complicated, if you like, than having one disease and one explanation and maybe one drug for it, which has been very much the drug discovery paradigm. So the study that those brains came from that I've just quoted came from this study, which has multiple locations and has been going on since the late 80s. And that study has been used to inform natural history and has shown that it's complex. We've shown that there is a relationship to risk which is present across the life course, and of course that's fed into the Livingston, the Lancet Commission work. So that across the life course there's a complex interplay between risk and protection, with education being protective, with physical activity being protective, and those two things being related, socioeconomic class being protective and social engagement being protective, social class through employment in midlife and social engagement in later life. And you can weave into that all the things which are related to inequalities. So we've found more recently that inequalities explain centre differences in dementia prevalence, which is really important, and it didn't 20 years ago. So there's something going on with inequalities in the UK. We can look at what biologies might underpin, and I've mentioned age, mixed pathology, and TDP43, which is a new type of dementia in the oldest of old that's being recognised more. What's really important here to note is that if you are in the oldest age groups, you can have lots of Alzheimer type pathology, but you can tolerate it and die without dementia, and that's quite important. And as you get into the oldest age groups, the relationship between the expression of dementia and the neuropathology becomes attenuated. So it's not quite so important in the oldest age, and that's where the age groups are increasing so dramatically, and they are mostly at the moment women, although there are increasing numbers of men. So we've been able to look at differences in geographies, and we've been able to look at changes in generations. And the really important thing here is that we have shown that across generations, dementia has gone down by around a quarter in this country. And it is probably due to life course interventions that whole societies have made into things like education, health of mothers, vaccination programs, and so on. Whether we'll see that playing out in the future, we don't know. But basically, dementia, age for age, has gone down in the UK over the generations that are in older age now. So inequalities I mentioned. Depression is common, but not as common as in other life eras. and it's possible that depression is going down slightly. We have a paper coming out on that across generations. But it is a complex, has a complex relationship with dementia, and it's very bound up with dementia and possibly a risk, as well as something which is attached to it in its expression. And there's a lot of frailty in the older population, so we may have less dementia, but we have an awful lot of frailty, and we have a lot of polypharmacy, and we have a lot of comorbidity, and all these things are associated with inequalities and poorer health access in certain populations. So these are all really important things you learn from population studies. And the other area that we can look at, of course, in the population studies is looking at the environment and the social interaction. Report and look at the history of those areas and those populations that we're studying. So that's just a really skate through some of the work that we've done, and I just really want to leave you with a message that it's really very complicated. Dementia is a kind of later life syndrome for most people, apart from the early onset dementias. And it's very, very complicated because it's so bound up with aging and our whole life context, but there are very positive messages as well as quite concerning ones. Okay, thank you.
Thank you. Well, could I invite all our speakers to come to the front and sit in these chairs? One of them is broken, but I'm not going to tell them which one until I think we fixed it. I'm going to turn this off, I think. I'm not telling you. Yeah, it's okay, we fixed it.
There's only one left.
Okay, yeah, we'll find out. It's not good. Good. So, so I have a lot of questions, but it's really the audience's time now. So, if you could put your hands up if you have questions for our panels. Just wait for a second. And I'll move around and give you the microphone. So I think we were first here.
Hello. I'm not really sure how to phrase the question, but it was more of a thought. A problem that I've encountered personally with experiencing not treatment in terms of medication, but in terms of mental health treatment has been feeling a bit erased in terms of my gender identity. And I've seen some mental health professionals who have never actually come across people who don't fall in the gender binary. Yeah. And I've come across it at least probably 5 times over the last 5 years, and I find it quite astonishing, really. I identify as non-binary, and I've been called kind of unusual or all kinds of things, and I think it's been mainly mental health nurses, but they've kind of talked to me through that kind of binary lens, and I found it quite difficult, and it's definitely had a poor effect on my mental health. But I know it was, the topics were relating to medication and kind of biological differences, but I was wondering if anyone had things to say on that. I don't know, it was just a thought that popped in my head, yeah.
I can say one thing, which is I think that the evidence base just simply isn't there. That's I think partly why there's a challenge here. Is that it's a phenomenon which is changing in cultures and societies rapidly across time, and we haven't really caught up. So all the therapeutics, all the evidence is based on usual male-female. I mean, male-female is often the term used as though we're lab rats. I mean, that's just a...
Yeah, I think most people have difficulty even understanding that there might be genders as opposed to, kind of at the most think of a 2 or 3, and then people, I think professionals find it increasingly very difficult to get their heads around a lot of this. And I know a wonderful project which in India is going around actually educating professionals on understanding gender and sexuality in a much more broader sense rather than just this kind of binary way of thinking about gender. So I think there's need to actually get professionals, especially health professionals, to understand these differences.
Absolutely, it can be quite alienating for people.
Yeah.
you know, kind of, what about me?
Yeah.
Thank you.
Thank you. Firstly, thank you for some really wonderful papers. I enjoyed it enormously. And my question is, I suppose, initially to Martin, but then to the others as well, which is, as a historian of emotion, I'm interested in how we take a diagnosis like depression and how we track it and how we compare it and how we do any sort of longitudinal work at all. So when we're looking at all the different variables involved, how do we know what people are talking about in different contexts, whether across time or cultures, with using something like depression? And I suppose linked to that is this relationship with mind and body. So we talk about mental health all the time, and yet so much of this is embodied and articulated through the body. And I was wondering how that broader perspective on the language used connects to these papers.
I can say very briefly that we thought long and hard about how to measure it and how to conceptualise it. So the actual scale that we used was validated within India, for example, the DAS. But that itself had its limitations and its problems, because people answered questions particularly in ways which were culturally framed and culturally bound. And we had to guard against their respondents giving responses which they thought that the interviewers wanted. We had particular dynamics going on. So the capacity building project was training students to become researchers, and the researchers were training students in some of the techniques of research. So we had students who were collecting data, supervised by faculty members, and there was a big age dynamic going on as well. So people were giving particular responses. So we had to treat some of the data with caution and maybe indicative. I think what you're also referring to is thinking about the connection of mind and body and mental and physical health. So we can look at it on one level as the interrelationship between risk factors and how you cannot treat one without the other, and we are complex human beings and both interact on each other. In India, particularly where mental health is stigmatised, people don't recognise it, don't want to recognise it, or if it is recognised within the family, it can be suppressed, it can be hidden, or not given a priority as a physical health condition might be. I think the economics of some of the dynamics of treatment are quite important. So within a family context, again, it might be certain members in the family who might be favoured for treatment, that might be a more of what is recognised and more of a socially acceptable physical treatment than perhaps for something which might look like depression. But we know that our understanding of depression, a Western understanding, can be quite different from in different parts in the world. I don't have a quick and easy answer to you, because I think that it is incredibly complex, and we're learning.
If I can add, I would say that mental health issue, brain diseases and mental ones are stigmatized a bit all over the world. So I wouldn't emphasize on India. I think we're still far from where we should be. And when we think about the future and how we should maybe solve the problem of how behavioral symptoms might correlate with pathology either in the brain or our body and the way it's influenced, the solution might be the digital future, where the scales that we usually use at the moment, where there is a problem of inter-rata variability and intra-rata variability, might be overtaken by the fact that digital ones will not be biased by the assessor, and there are also evidences pointing to the fact that when we have, whether we like it or not, this can be discussed, but when we have an interface like a computer or a technological device, we are more prone to share. So it's very well known that suicidal thoughts are very often shared with a computer rather than with your mother or your beloved ones, right? So I think that, especially mental health and the neurological disorder, digitalization might be really the much needed solution for optimizing the clinical trial development and also monitoring how we respond to drugs, preventing suicidal attempts, etc.
Can I just add to that a little bit? I think it's interesting, but in many cultures and in many languages, there is no equivalent word for depression. And so, does that mean depression doesn't exist? Of course not, it does exist. But it's not conceptualized in that kind of diagnostic, categorical way that Western biomedicine tries to categorize it. So in India, for example, if you try to talk about depression to people, they don't really get it. And in all our work, increasingly, that's why we don't take a diagnostic approach, but take a very trans-diagnostic approach. Clearly, people are distressed and people have mental health issues, and there are ways of expressing that distress, and there is a language for it in their own cultures. And I think what you need is, rather than try to go in with these square pegs and try to fit these into these round holes, it might be a good idea to actually start with the round holes and say, okay, how do we structure a world and understand a world we're using these round holes? So we do a lot of our work, we don't do diagnostics at all. We take a trans-diagnostic approach in saying we're going to deal with distress and functional impairment, the things that matter to people's lives. Diagnosis does not matter to people's lives. What matters to them is distress, what matters to them is functionality, what matters to them is what do they do with their lives. And if you take that approach, that's different. I think the diagnostic approach is largely driven, and this kind of a single disease, single disorder, condition issue is largely to do with the need for development of drug therapeutics and all, which requires these kind of homogeneous categories, whereas cultures really don't need those kind of homogeneous categories of distress. So I think we need to really look at it slightly differently than just think about this from a purely, narrowly health, physical, biomedical health perspective.
Thank you. Next question.
Just a general question with regards to pharma and pharma industry and Roche, perhaps. How does mental health research and drugs and diagnostics, the funding that's allocated for those activities compared to the other, perhaps more?
Well, I have to say that the funds allocated to neuroscience, and this is not only pharma, this is in general, when we compare to what gets allocated to oncology, is really little. And this is a matter of concern. I would say that nevertheless, neurological and mental diseases are still a big unmet need, and this is where also pharma companies are very much aware. So they are prone to invest and to find solutions because there is a huge unmet need. And this is not only, this is my personal opinion, it's not only about drugs, but it's also diagnostic. I was working in a hospital for 6 years, and I was so frustrated of not being really able to diagnose my patients with a certain type of disease. It was always clinically possible in dementia of Alzheimer type, translated now in English. I was working in a German setting. And, I very much believe that we should shorten the time to arrive to a very precise diagnosis, much as we do with oncology. So in my understanding, the developers are really willing to explore this pathway because it is still uncontaminated in a way. So there is a lot of opportunity of having also returns in terms of optimizing treatment, diagnosis for patients, and also then what is their business model, which has to be nevertheless sustainable. Right?
So, I think it raises a really important question about investment into research and the balance of investment. And recently the Alzheimer Society have had an exercise where they've tried to look at what might be the research roadmap that you would balance, as it were, the investments. There's been $500 million promised in a public-private set of partnerships to specific dementia-type research, Alzheimer's, and mechanistic research and drug discovery. And it's not balanced in any way by an investment, by a similar investment, which would be capacity building and expertise, interdisciplinary research, social, ranging right the way through all the different disciplines required. And we're actually working really hard to try and bring that up, but it's very hard because it's not as attractive. And the fact is that the drugs, the trials to date in Alzheimer's and mild cognitive impairment and depression drugs, you can talk about perhaps the medication because that's also a difficulty in terms of recruitment. But for dementias, the age groups and the representation of the types of people who actually get dementia and are the societal concern, they don't map well. So when we do have drugs, they will probably work for very specific groups, and that'll be brilliant for those people. It'll be marvellous, as long as there aren't horrible side effects. But for complex, frail, older people who are nearing the end of life, because that's where a lot of dementia happens, that approach will have to be much more nuanced about our approaches. So I think it's a really, really good question.
Anyone else?
I didn't have a question. Are we still broadcasted?
I'm sorry?
Are we still
I think we are, right?
Yes.
Let's assume we are. Until we find out differently. Nobody make any rude comments.
There are a huge number of complex issues, both in the problem and the possible solutions to global mental health problems. I was wondering if any of you wanted to mention any potential low-hanging fruits that still remain for progress in mental health policy and research. Things like friendship benches, things like banning the most toxic pesticides to reduce suicide, and other areas that have been traditionally neglected.
I don't like the term global mental health for various reasons, but leaving that aside, I mean, won't get into that for now, but coming to your point, which is about what can we do globally to try and improve mental health for populations. And I think some of the things that you suggested are very appropriate, and friendship bench especially is a good example of a great innovation which started off in a low and middle income country, is now moving to a high income country and is seen as being something that is applicable. So this is something that was developed in Zimbabwe and is now being copied in New York. And so that's an amazing example of how innovation actually can work both ways. It's not always innovation has to move from high income to low income country. And we have a similar thing that we've developed in India, which we are just in the process of reporting. I think while there are commonalities of what we should be doing across the world, I think it's very important that those interventions and treatments are actually culturally appropriate and have some sense of a bottom-up approach to developing them. Otherwise, you start getting this kind of imposition of treatments, which I think is a problem. I don't think that you said low-hanging fruit and you gave a lot of examples. I don't think those are low-hanging fruit either. You know, getting a ban on toxic pesticides is not an easy job. It's easy maybe in Sri Lanka because of Sri Lanka's specific geographical status of it being an island, not having any pesticide producers in its own country. It's easy. Try doing that in India. It's close to impossible. Because we are the hub of pesticide manufacturing, and we are not an island in that sense, and so controlling this would be very difficult. So I think there are a lot of geographical and political and social realities in trying to implement solutions for mental health issues, and I think we need to keep that complexity in mind when we try to do that, firstly. And secondly, it's not a one-size-fits-all thing, so that needs to also be taken into account. I mean, I could go on and on, but I'm going to stop. I'm happy to kind of have a back and forth if you want. But
if I may add just a thought that I had, I'm not sure it's a low-hanging fruit, but something that is happening and we should capitalize on is the technology, having simply Google there. So some doctors hate it, that people just check for their symptoms and they get a diagnosis on Google. On the other hand, I think that this is empowering people. And I think one way in the future to improve mental health will be to empower, especially young individuals, to get right information, to know what's happening to them, to know what they can do to improve their own health. And so this is something that can be done with awareness campaigns and with proper information on the internet. So my thinking is that empowering each individual via the technology that is available is actually a very viable way that could be implemented.
I have two suggestions. Again, probably not low-hanging fruit. Anti-stigma campaigns, international, they are in many, many countries, but those need to be done and rolled out continuously. And that needs to be brought into training of practitioners. Mental health literacy across the health and social care profession is absolutely essential. And within that, about respecting the needs of individual people, looking at people as individuals.
I actually have a comment regarding the stigma.
Yeah.
It relates to what you mentioned. I don't know if you see where I'm going, but you rightly said that it might be important to shift the focus from the health issue of mental health towards the human rights. And I totally see the reasoning and the point. At the same time, I very simply think that to remove stigma, the easier way would be to say that mental health issues or conditions are a disease of the brain, the same way we can break our arm, we can break some synapses and we lose the function of the brain. So part of me thinks that pushing it as a health issue is the way to remove stigma, because then you're not ashamed of breaking your leg. Why should you be ashamed of having depression, you know? But then it might be cultural as well. So I don't know.
No, it's not cultural. Well, it's an interesting thing. We all thought that, if you had a biomedical explanation for mental health, that would reduce stigma, because it would take away this notion of you are responsible for it. But the research is actually completely different. People who believe in a biomedical perspective on mental health, that it's an illness, exhibit higher rates of stigma. Stigma is more when people believe a biomedical cause for mental health. So it's not a very straightforward relationship. By making it a very biomedical health condition, we will reduce stigma. And the other issue is, I'm kind of not a fan of stigma, anti-stigma work. If you look at stigma research, there's been tons and tons of stigma research now. And the only anti-stigma measure which has worked across studies and across years is contact with people with mental health problems. Okay, that's the only thing we know reduces stigma. I mean, Time to Change in the UK has invested a huge amount of money and has brought about very little reductions in people's attitudes towards mental illness. I mean, I know they say, 9%, but I mean, 9% is not a huge number. In fact, what we need to really do is, I think as human beings, we'll never stop stigmatizing someone or the other. And so stigma is really going to be with us for the rest of humanity, in a sense. What we need to really focus on, and that's something I believe very strongly, is focus on discrimination. And that we should focus on removing discrimination because it impacts people's lives directly. And secondly, it's measurable. It's behavioral, it's measurable, it's amenable to policy action. Whereas stigma is in your head, and you can't really get it out of people's heads. And in fact, paradoxically, if you reduce discrimination, you would see that people have much more contact with people with mental health problems, and you would actually reduce stigma. So I think it's not about reducing stigma to reduce discrimination. I think it's about reducing discrimination to reduce stigma is probably the way forward, because discrimination is something that's behavioral and measurable. I think you're welcome to think what you think about your neighbor, but your neighbor has a right to be there as much as you do, however they look, whatever they are, whoever they are. And I think that's the message we should get across with the whole stigma issue. And the word stigma and discrimination gets used, as if they're brother. It's in one sentence, stigma and discrimination. They're not. We need to focus only on discrimination.
Although I think, if I can bring another perspective, at least in the Western society, there was a lot of stigma around cancer a few years ago. Nobody wanted to share their cancer diagnosis, right? I mean, it was quite a stigmatized condition. By improving the way we treat this medical condition, by the way we diagnose it, improving the diagnosis, I think we have removed a lot of stigma. And now to talk about cancer, it is just, first of all, it is
but you didn't have discrimination.
But it's also,
you didn't
by
have
improving
discrimination.
treatment, by improving diagnosis, I think you remove the stigma. And whether then it goes around with discrimination, well, I'm not an expert on this, but I think that one way to remove both, most likely, stigma and discrimination, is really to do all we can to improve care, to improve diagnosis, and to share eventually.
Well, we have institutionalized structural discrimination about people with mental health problems across societies, which you didn't have for cancer maybe. And that unless you tackle that kind of institutionalized thing that is done, you're not going to get rid of stigma. You can tell me anything, I should accept my mental health problem. But in India, if I accept my mental health problem, that could mean that I might lose, my spouse has a right to then divorce me, and I might lose control over my children. Then it's all very well to accept your diagnosis. I suffer serious loss if I were to accept that diagnosis. You're not going to go away unless you remove this institutionalized discrimination. You're not going to get people saying, oh, I have a depression. I mean, why would I say I have depression if I could lose my children? I'm not going to say that. So I think with cancer, maybe we never had that institutionalized discrimination.
Exactly. But I think it also goes down with cultural differences and the societal setting. Because I think there are societies where we are much more advanced. I mean, if I think of North European countries, for example, this type of institutionalized separation from mental and brain diseases is already gone since quite a while, luckily. So I think it's, we have to try to progress and learn from those who are doing better.
I think we're going to wrap it up. Carol just had one last, the last speaker, maybe you get the last say in this discussion.
Well, I was going to say something different. I was going to say something which wasn't related to that last point, but it was about the concern about medicalisation and quantification, quantified self, and maybe there are some sections of society, particularly in high-income countries, and possibly the rich in low and middle-income countries, who do embrace the idea of the quantified self and everything being tracked, and actually you have your wearable on you. And there are others, though. There are others, and I think the marginalised and the lower, people in poverty and so on. The concept of it all being done in a quantified self way probably is very alien. And there's another group, possibly, or mixtures of these, who think that the picture that you portray is a bit. There's a book by David Egger called The Circle. It's a kind of dystopian future where we aren't really people. This is the whole discussion about the boundary between humans and machines, I think. And I think it is something we really, really need to. We need social scientists and historians and cultural analysts to understand what it means for us as what this means for us as humans. It's just not an automatic good.
We need philosophers, we need ethicists.
Yeah, absolutely, and the law and the whole gamut.
Thank you. It's been a fantastic discussion. Could you join me in thanking all our speakers once again for that? And thank you all for coming. And you can stop the recording now.